Our first speaker this evening is Dr. John Lippman. He is a board-certified interventional radiologist and renowned authority in the non-surgical treatment of uterine fibroids. He received his medical degree from Georgetown University School of Medicine in 1985 and completed his residency in diagnostic radiology at Brigham and Women's Hospital, Harvard Medical School, and his fellowship in vascular and interventional radiology at Yale University School of Medicine. He has been awarded fellowship status in both the American College of Radiology and the Society of Interventional Radiology, and these are honors that less than 10% of radiologists ever achieve. He has delivered over 200 lectures on uterine fibroids to many prestigious institutions and serves on the board of directors of the Medical Association of Atlanta and Cobb County Medical Society. He serves on a number of boards of healthcare platforms and has received several awards for his achievements. Dr. Lippman is the founder and medical director of Atlanta Fibroid Center, a state-of-the-art medical facility that specializes in the non-surgical treatment of uterine fibroids. He is also an adjunct clinical assistant professor in the Department of Obstetrics and Gynecology at Morehouse School of Medicine. Dr. Lippman, we're eager to hear your presentation.
Well, thanks very much, Deanna. It's really an honor to be a part of this very distinguished panel. And I want to thank you and the members of Phi Pi Omega chapter of AKA for the invitation. It's such a it truly is such an important conversation. And so it's with that backdrop, it was an excellent summary about fibroids. Hopefully I can, there we go. I'm going to be talking about a specific procedure. As you mentioned, the procedure is called uterine fibroid embolization. U for uterus, obviously, F fibroid, and then E embolization. Embolization is when particles are injected into a blood vessel to either stop it from bleeding in a trauma situation. It can be used to cut the blood supply off to a cancerous tumor, which we have done for many, many years prior to the discovery of this procedure, or in this case, a benign tumor. As a number of things in medicine, this procedure was discovered entirely by accident. We've been embolizing tumors for many years for cancer to make it an easier operation. You decrease the blood flow to a malignant cancer and it makes it easier to remove from the body. In 1979, an investigator in France, Jacques Ravina, decided, well, why don't we do that for fibroids? Fibroids are very vascular tumors. We can cut the blood supply off prior to a hysterectomy and make it an easier surgery for the surgeon and the patient. Made sense. And unlike this country where we embolize a tumor, they're in the operating room the same day. In France, the healthcare system is socialized medicine. So you have to wait for your elective procedure. So a number of patients were embolized and then they were sent home and they had to wait for their elective hysterectomy. They would wait 6 weeks, 7 weeks, 8 weeks prior to getting hysterectomy. Well, what happened? Over that 6, 7, 8 weeks they were waiting at home, a number of these patients' symptoms entirely disappeared. And so the question became, do I really need that second part? Do I really need a hysterectomy? And they started looking at it, and the answer is no. You don't need to have a hysterectomy at all. All you need is the embolization. And Jacques Ravina published his first series of 16 patients, only 11 of which had complete resolution of the symptoms before the operation, and only 2 of them actually decided to, out of the 16, decided to undergo the hysterectomy procedure. And that started an evaluation in this country. It sounded exciting. And so Scott Goodwin at UCLA published the first series of 11 patients in the United States done with uterine fibroid embolization alone as a treatment option for fibroids. And later that year, I did the very first procedure here in Georgia and was part of a national fibroid registry, which is still the largest repository of fibroid information. And in 2022, now we have the Atlanta Fibroid Center. We've been around a number of years, and we have a very large experience one of the largest in the world, if not the largest, according to some, 10,000 women treated now at our center. Just some facts about hysterectomy, because that's what we're trying to replace. Hysterectomy is the second most common surgery done in the United States. That may seem surprising to some. It was surprising to me because half the population doesn't even have a uterus. It's a very common procedure. 1 in every 4 women by the time they're 40 years of age has already had a hysterectomy. 1 of every 3 women by age 60. 80% of African-American women have fibroids, and their fibroids tend to be bigger and more numerous. They happen earlier in life, and that means more likely they're going to end up with hysterectomy than any other racial group. The average age of hysterectomy in this country is less than 40. And I must tell you that over the years of doing this, I've been treating fibroids for over 25 years. I've seen way too many women less than 30 have already had a hysterectomy for fibroids. They didn't want it, but they weren't given any other option. And again, we're talking about benign tumors. Here's a study out of Meharry showing how the hysterectomy rate is very different depending on race. For African-American women, you can see at the top here, they have a much higher hysterectomy rate than their Latino or Caucasian counterparts. And it peaks, as I mentioned, late 30s, early 40s. And it's staggering the difference. And so the question becomes, why are we doing hysterectomies for fibroids, which are benign disease? Cancer, yes, appropriate, but fibroids are benign. Well, very commonly, I'll hear patients tell me, well, I was told if I was done having my children, I don't need my uterus anymore. And that's just ridiculous. The uterus has a lot of very important functions for women besides childbearing. It's not the appendix. There are psychological issues. A number of women feel less of a woman. It's the epicenter of their womanness, and they can struggle psychologically like a man being castrated. It can certainly cause sexual dysfunction, loss of libido, loss of orgasm. We know it causes a lot of bone loss, urinary leaking, even heart health. A number of studies have been shown that most women with symptomatic fibroids only hear about the surgical options, and that's wrong. You'll hear about another less invasive surgical option shortly, but uterine fibroid embolization is entirely non-surgical, no surgery whatsoever, but women aren't aware of this option at all. A study from our society in 2017 with about 1,200 women, over half of them were never told about UFE as a treatment option. And the ones that did hear about it, 3/4 of them didn't hear it from their gynecologists, who were obviously the gatekeepers of women's health. And so when there are misperceptions about uterine fibroids and the treatments that are available, that leads women to getting more invasive and potentially unnecessary hysterectomies for their fibroids, despite the fact that UFE has been available in this country for the past 25 years. It has a long track record of safety and efficacy. Oops. Here's another study from Ebby Stewart, chief of gynecology at the Mayo Clinic, looking at about 1,000 women with fibroids. The mean time to treatment was over 3.5 years. These people are waiting on the sidelines. We call them the silent sufferers. Over 25% of the women waited over 5 years. And when they were asked, why are you waiting to be treated? You got these horrible periods, horrible pain. Why are you suffering in silence? They didn't want surgery. They don't want hysterectomy, and I don't blame them. And they weren't told about non-surgical options like UFE. Well, what is UFE? It's a completely outpatient, non-surgical procedure, as I mentioned. Patients come into our center here at the Atlanta Fibroid Center. The procedure takes about 30 to 40 minutes. They go home after several hours of recovery with a Band-Aid, either at the top of their right leg or on their left wrist. A Band-Aid, that's it. Each uterine artery, and there are 2 of them, they're each like a tree and they each branch, getting smaller and smaller branches. The fibroids are like the leaves of the tree, and I can steer a little tiny microcatheter, it's like a piece of spaghetti, into each of the uterine arteries one at a time and deliver these particles. As I mentioned, embolization delivers these particles to cut the blood supply off to these benign tumors. Without a blood supply, these fibroids are going to die. And as they die, they soften and they also shrink. And as that happens, a woman's symptoms go away. And you heard from Dr. Guthrie the main symptoms of uterine fibroids. The big three are heavy periods, pelvic pain, and increased urinary frequency. And there are others. And this is a slide just to kind of give you a comparison of UFE versus surgical hysterectomy. And you can see UFE is much less invasive. It's much safer. It's outpatient. There's no general anesthesia. There's no hospital. And patients go home the same day with a Band-Aid with a very short recovery. And importantly, and often underappreciated by many physicians, you get to keep your uterus. Here are two schematics showing what a UFE procedure is. There, the approach is at the top of the right leg here. And you can see a little tiny catheter is in the left uterine artery. There's also a right. And then you can see fibroids here depicted and the kind of magnification view, these particles, and they're made of what's called polyvinyl alcohol, PVA. It's the material that contact lenses are made out of. They're entirely inert. They don't react in any way, and the patient doesn't know they ever have them. They're like microscopic medical implants. Here's actual angiographic pictures. You can't really see the tip of the catheter, but it's about here where the arrow is. And we're injecting, and you can see there's a number of these kind of circular areas. The branches we're embolizing are at the periphery of each fibroid. So you don't see the fibroid per se, but you see these little tiny branches. And then as we knock off the blood supply, you don't see them anymore. You see the main uterine artery here. And if we continued, you'd see slow forward flow in this main uterine branch, but you wouldn't see any of the fibroid branches. Here are two pictures of a patient prior to uterine fibroid embolization and 3 months later. They're side view pictures, and this is an MRI, which is a much higher resolution imaging tool than ultrasound, which people are more familiar with. The front of her is on the left. You can see the bladder here in front. Here is the uterus. Within the uterus, you can see this black circle. This is a fibroid about the size of a small orange. And 3 months later, it's like a pea size and all of her symptoms are gone. Here's another patient, very large fibroid in the uterus. It's bowing her out, making her look pregnant. Nobody wants to look pregnant when they're not pregnant. And 3 months later, you can barely see where that fibroid was. And again, all of her symptoms are gone. Patients will stay several hours in our center and go home the same day, as I mentioned, with a Band-Aid, a very short recovery. All insurances cover this procedure. We've been doing it, say, in Atlanta for 25 years now with outstanding results. A little bit over 90% of women will get either significant or complete resolution of all their symptoms, whether it's bleeding, pain, urinary frequency, what have you. The procedure has no limit for size or number. I'll hear all sorts of kind of what I call urban myths about UFE. Oh, my doctor said I wasn't a candidate because my fibroid is too big or I have too many. Doesn't matter how big or how many. It treats all of them, which is a real advantage to knocking out all the fibroids. In fact, only hysterectomy is the only other procedure that can knock out all the fibroids because it's being removed. UFE also knocks out all the fibroids without removal. Therefore, the recurrence of having to do this more than once is unusual. It happens, but it's very unusual to treat a patient a second time. It treats all the fibroids all at once. It's very effective. It's minimally invasive. It's typically a one-time procedure. There's no surgical wound. There's no general anesthesia. There's no blood loss. We treat lots of Jehovah's Witnesses and people that don't accept blood products, or patients that have hemoglobins way below what you could ever safely operate on. And importantly, as I mentioned, you get to keep your uterus. Disadvantages, not everyone, say 90% success means there's about 10% that at least initially don't get the relief. And usually it's something we can fix. It's usually due to a collateral supply of these fibroids from a secondary blood supply, most notably the ovarian arterial branches. There is some pain afterwards, and the pain has been something that we've been a lot better at treating ahead of time. In years gone by, post-procedural pain was much more of an issue, but in the last 3, 4, 5 years, it's very unusual to see somebody that has the post-procedural pain that we used to see more commonly. It's usually crampy, uncomfortable, but not excruciating. It's done under X-ray, but with a 30-minute procedure time and a 4-minute, 5-minute X-ray time, it is less than a CAT scan. It's like a mammogram. It's very small medical radiation dose. Risks, there are some women that don't menstruate permanently, although I've never seen it in anybody under the age of 40. As you get above 40, it's a small risk, but these women are typically not interested in fertility when you get to your mid-40s and 50s. We've had a small number of patients need an elective hysteroscopic D&C to kind of deliver some fibroid material out. So in conclusion, if you suffer with fibroids, it's really important to know about UFE. Compared to surgery, it's safer, it's less invasive, it costs less, the recovery is shorter, and you get to keep your uterus. There's excellent results. Patients tolerate the procedure very well, high patient satisfaction. They're back to work quicker, the employer's very happy, the patient's happy, and you just don't have to have surgery, but you do need to get a second opinion from an interventional radiologist, because those are the types of doctors like myself that do uterine fibroid embolization. And with that, I really appreciate your attention. These are some ways to reach me or my office, and I look forward to answering questions after Dr. Hawkins' talk. I would echo that. It's really smart. I would bring somebody with you to the appointment, because sometimes people hear the word hysterectomy and then they shut down. Be armed with questions. Nobody knows your body better than you. And if you're feeling dismissed or people aren't listening, your doctor's not listening to you, or you're being dismissed, there are plenty of other doctors that will listen to you and spend the time with you. It's really important. And so unfortunately, you do have to kind of advocate for yourself, but I would suggest bringing somebody with you, be armed with questions, and if you're not getting the answers that you want, go elsewhere. And as I say, just because you've been bleeding heavily for a long period of time, as Dr. Hawkins mentioned, that does not mean it's normal. And so that's a very important point that needs to be kind of reinforced.